Welcome to Falcon Physician Review's Neurology Review. This section will cover brain vasculature. The most important structure when you talk about brain vasculature is the circle of Willis. This is an incredibly important vascular structure that allows us to survive what otherwise would be pretty major strokes. This allows us to, even if we occlude one of the carotids, we may feed that side of the brain with the other carotid or even from the posterior circulation. Because these areas are so connected to one another, any drop in blood flow from one side can be filled by the other side. Let's go through these structures. First of all, the internal carotid will bifurcate to form the middle cerebral artery and the anterior cerebral artery. That constitutes the anterior circulation. And if that were all there was, well, a single carotid occlusion would certainly cause a big stroke. However, because we have the anterior communicating artery, which is a structure between the two anterior cerebral arteries, that allows us to feed one side to the other for the anterior circulations. In addition, we have the posterior cerebral artery coming off of the posterior circulation. This will feed the back of the brain and some of the thalamus. The connection between the posterior circulations and the anterior circulations is subserved by the posterior communicating artery. This artery allows these two circulations to communicate, and therefore, even if a person had both carotids occluded, as long as they have an intact posterior communicating artery and good flow into the posterior circulation, they may be able to survive that stroke with minimal deficits, as long as the blood pressure is able to rise enough to feed the entire brain off of the posterior circulation. Let's look at the circle of Willis and its relation to the rest of the brain. Here you see the internal carotid arteries and anterior communicating arteries and anterior cerebral arteries, as well as the posterior cerebral arteries and posterior communicating arteries surrounding the pituitary gland. Looking at it with an angiogram, one can see how flow could be changed if a person has an occlusion or stenosis, for example, of the posterior circulation. The blood can flow through the internal carotid all the way across the anterior communicating artery into the other side's middle cerebral artery. Right now we're not looking at the posterior circulation. We're only looking at the anterior circulation because an angiogram was shot up one of the carotids. So here's what you see when you shoot dye up one carotid, and the other, and that carotid is responsible for the blood flow to the entire anterior portion of the brain. So this one carotid is supplying both the left and right, anterior and middle cerebral arteries. Here's another set of images that show you how we look at the brain vasculature in the clinic or in the hospital. The image on the left is an MR angiogram that shows the vessels going up to the brain, primarily the bilateral internal carotid arteries and the two vertebral arteries. You can see the two vertebral arteries coming together to form the basilar in the upper left portion of the brain, upper left portion of the image. On the upper right portion of the image, you see another MR angiogram, which shows the anterior and posterior circulation through MR imaging. The bottom image is an angiogram, conventional angiogram of the posterior circulation, where you see both vertebral arteries coming together to form the basilar artery and later splitting to form the two posterior cerebral arteries. Let's talk about how the brain is fed by different arteries. The anterior cerebral artery gives blood supply to the parasagittal regions. That would correspond to the leg portion of the homunculus, or the representation of the body in the brain. So here's an image of the medial portion of the right hemisphere. This shows the anterior cerebral artery wrapping around the corpus callosum and feeding the medial portions of that right hemisphere. You have two anterior cerebral arteries, one for the right and one for the left hemispheres. So if a person were to have a stroke or a clot in this right anterior cerebral artery, the main portion of the body that would be affected would be the left leg, because the main portion of the motor strip that is subserved by that medial hemisphere is the leg portion of the body. What are the territories of the anterior cerebral artery? Here you can see this anterior cerebral artery feeds primarily the medial portion of the brain. So it will certainly get mostly the motor cortex and sensory cortex of the leg, not the rest, not arm and face. We'll see that differently when we cover the middle cerebral artery. The middle cerebral artery covers the rest of the pre- and post-central gyri. Therefore, an ischemic stroke of the middle cerebral artery, if it's a distal occlusion of the artery, will affect primarily the face and arm. So the face and arm may be weak and numb in a distal middle cerebral artery occlusion. However, the middle cerebral artery also gives blood supply to the basal ganglia and to the internal capsule. Now, that internal capsule is going to have white matter tracts that subserve the leg as well. So if I were to have an ischemic stroke of the proximal portion of the middle cerebral artery, I'm going to get not only a face and arm weakness and numbness, but I could also get the leg involved as well, just because the fibers themselves are being damaged by that stroke. The middle cerebral artery is seen here in an angiogram, where it has been injected with a radio-opaque dye, and you can see that it primarily feeds the lateral portion of the hemisphere. Here's another schematic of what it is, what areas of the brain is fed by the middle cerebral artery. And here again we see the same picture we saw previously, and this time we would just focus on the middle cerebral artery and what it subserves. So certainly speech would be affected in a middle cerebral artery stroke, certainly on the left side. A little bit of the vision, but primarily what you think of for visual deficits is a posterior cerebral artery stroke. Let's talk about the posterior cerebral artery. This artery supplies the medial occipital lobes, that is the primary visual cortex. Therefore, posterior cerebral arteries lead to primarily visual field deficits. And the person may not even notice it because the brain fills in that blind spot quite well. That's why it's really important when you're doing an exam to check visual fields, because the person may say, no, there's nothing wrong with me, but they're coming in with a car that's got the mirror hanging off of the right side, and they've had a lot of accidents on the right side of their car. The posterior cerebral artery also supplies blood to the hippocampus, so it's important for memory formation, and a stroke of bilateral posterior cerebral arteries could lead, certainly, to memory deficits. The thalamus and hypothalamus are also fed by the posterior cerebral artery, so think about if there were small strokes within the thalamogeniculate vessels, these vessels that are coming off the posterior cerebral artery to feed the thalamus. A small stroke there, such as a lacune, may lead to predominantly sensory deficits. Let's look at an image that shows what an acute stroke looks like on CT versus MRI. CT is unable to pick up a stroke until approximately 6 hours after the stroke onset, whereas diffusion-weighted MRI, seen below here, is able to pick up that ischemic stroke quite early. So here you see the difference between a CT scan and an MRI scan side by side. Here's a type of a stroke that tends to occur if a person has a global loss of blood pressure. These are called watershed zones. And so this is a CT scan, and you see 4 areas of darker portion of the brain. Those are exactly in the areas that are right between major vascular territories. So the anterior cerebral artery and the middle cerebral artery have a watershed zone between them, and that can be damaged if global blood pressure decreases. And the posterior cerebral artery and the middle cerebral artery also have a watershed zone between them, which is most susceptible to global decrease in blood pressure. And that area will have a stroke if all blood pressure drops down. So here you see the 2 watershed zones on each side, making a total of 4 watershed zones seen here. These vessels can not only just have an ischemic stroke, but also 15% of these strokes will be hemorrhagic. Primarily, these are due to hypertensive problems. So if a person has a very large hypertensive event, they could have strokes primarily in places like the thalamus, the basal ganglia, the cerebellum, and the pons. These are because you have these small vessels that I mentioned before, thalamo-geniculate coming off the posterior cerebral artery, lenticulostriate arteries are small vessels coming off the middle cerebral artery going to feed the basal ganglia and internal capsule. The pons has perforators from the basilar, and the cerebellum has a propensity to bleed from hypertensive emergencies as well. So these are the four areas that you would suspect would be at risk for a hypertensive hemorrhage. Here's what it looks like on a CT scan. Blood shows up very well on a CT scan if it's in the acute stage, so a CT scan is a good way to rule out hemorrhage if you suspect that the person's having a hemorrhagic stroke. So here you see a bright region in the middle of the brain on a CT scan that corresponds to blood from a hypertensive intracranial hemorrhage. Other types of hemorrhages that are not necessarily within the parenchyma of the brain are subarachnoid hemorrhage. These are usually associated with an aneurysm, but can be from trauma. This image here shows a lot of brightness in all the major sulci of the brain, and that is blood. So those are subarachnoid. That is due to subarachnoid hemorrhage. And this person would tend to have a thunderclap headache, a rapid onset, severe headache, the worst headache they've ever had in their life. Subdural hematoma is usually seen in elderly people. This is an area where blood is draining from the veins of the brain into the venous sinuses, and as the brain atrophies away from those regions, those bridging veins get stretched. Any small movement of the head or trauma, mild trauma, turning of the head rapidly can sometimes tear these bridging veins, and then venous blood will slowly accumulate in the subdural space. It looks like a crescent rather than a convex shape, and I'll show you the difference between the subdural and the epidural hematoma. This you should see as a chronic, slow, insidious hemorrhage that can be seen in elderly people. An epidural hematoma is more seen as a rapid onset and due to trauma usually. When there's a fracture of the squamous portion of the temporal bone, you may rupture the middle meningeal artery, and since that is an arterial hemorrhage, it can accumulate quite rapidly. The person is usually seen as having a lucid interval where they lose consciousness with the initial trauma that broke the squamous portion of the temporal bone, and then as they wake up they say, "Oh, I'm fine," but then the blood is accumulating in their brain or outside the epidural space, and eventually they begin to herniate. Their brain starts to squish through places where it shouldn't be, and then they lose consciousness again. That's called a lucid interval, and this is more of a rapid onset thing than subdural hematoma. In addition, you could see that the accumulation of blood is more convex in shape than concave, meaning it has more of a ball shape, and that is because the cranial sutures of the skull keep the blood from tracking over a long distance. The subdural hematoma doesn't have that sort of a restriction to its movement, so it creates more of a concave shape. Let's do a clinical vignette. A 40-year-old male complains of the worst headache of his life and double vision. He has been vomiting. He has no history of fever or neck stiffness. Papilledema is seen on fundoscopic exam. His right eye is deviated laterally and downward due to right third cranial nerve palsy. Other cranial nerves are normal. No meningeal signs are noted. Motor system examination is normal. Well, this person has had the worst headache of his life that came on in a thunderclap. He also has double vision, and it's likely that there's an aneurysm impinging on his third cranial nerve. And indeed, when we look at the CT scan, we see that he's had a subarachnoid hemorrhage, which, as you remember, is often due to aneurysm rupture. The accumulation of blood in the sulci is quite clear in this picture. This should not be so bright in those areas of the interhemispheric fissure and in the lateral fissure, or sylvian fissure. Let's do another clinical vignette. A 65-year-old white male develops sudden severe headache and right-sided hemiplegia. The patient is a known hypertensive and takes his medication irregularly. He now has both urinary and fecal incontinence. On physical exam, you see severe hypertension. His blood pressure is 215/120. He has no fever. He has a dense right-sided hemiplegia. The fundoscopic exam shows presence of papilledema in addition to hypertensive retinopathy. He has a right-sided Babinski. The one thing that would argue that this is not a clear an ischemic stroke is that he's already got papilledema. The brain does not swell that quickly in an ischemic stroke, so there must be either a tumor or some mass pushing on the brain to keep the intracranial pressure up so much. If we look at him with a CT scan, indeed we see that he's had an intracranial hemorrhage, likely due to his hypertension. Another vignette, a 19-year-old female Olympic horseback rider is brought into the emergency room with a headache, confusion, weakness of the left side of her body, blurred vision, and projectile vomiting. 3 hours ago, she hit the right side of her head when she fell from a horse during a training exercise. She lost consciousness for 1 minute and then appeared to have recovered completely before presenting with the symptomatology. That sounds like a lucid interval. On physical exam, you see that her blood pressure is mildly elevated. She has bradycardia. She has papilledema, right-sided mydriasis, an efferent pupillary defect, reflex abnormality on the right side. She has deviation of the right eyeball downward and outward. So that argues for a cranial nerve 3 palsy, which would be very concerning in this case because she's likely herniating through the tentorial notch, and that means that she has third nerve compression and she's at risk for having death actually here. So if we were to look here, we would see a convex-shaped accumulation of blood. This is an epidural hematoma. She had, when she hit her head, she fractured the squamous portion of her temporal bone. She ruptured the middle meningeal artery. She's developed an arterial hemorrhage inside the skull in the epidural space. Related to this, we should talk about herniation. There are really two major and important for step 1 types of herniation. I'll talk also about subfalcine and external herniation, but the two that you really should remember are uncal herniation and tonsillar herniation. First, let's just mention subfalcine herniation. Subfalcine herniation is referring to a mass effect that pushes the cingulate gyrus underneath the falx cerebri. As seen in this slide, you can see that the gyrus has squished out from under the right side of the brain into the left side of the brain. Now, this is not really something that you can pick up by a clinical exam. It's really a radiologic finding. And so it's just something that the radiologist might make a comment of and say, well, you know, there's mass effect, and yes, there's subfalcine herniation. But it doesn't really change your management tremendously to know that. On the other hand, uncal herniation will change your management markedly. The uncal herniation means that the brain has been squishing down through the tentorial notch and maybe even compressing on the midbrain. This usually is seen clinically by an enlarged pupil and deviation of the eye down and out, as the third cranial nerve, the oculomotor nerve, is compressed by the uncus, or the medial portion of the temporal lobe. So here you see the proximity of the third cranial nerve to the uncus, and this is looking at the bottom of the brain, and you see the optic chiasm as well as the pituitary gland, and you see the uncus where it could really squish against the oculomotor nerve, against the brainstem. This is an emergency and should be taken care of quickly with hypertonic saline or mannitol to try to decrease the brain swelling. That would allow there to be more room in the intracranial vault to try to relieve the pressure on the brainstem. Now that's just really a temporizing measure as you get at the cause of the swelling, but at least that would be one sign that you could, that's one thing you can do to extend your time to fix the situation. Let's talk about, let's show you the MRI scan of a bad uncal herniation. This is a large mass that has pushed the portion of the medial temporal lobe through the tentorial notch down against the brainstem. And you can see the arrows pointing to areas of necrosis and an area where the hippocampus, or the medial portion of the medial temporal lobe, is pushing against the pons and midbrain. Tonsillar herniation is also quite clinically important. It occurs when the lowest portion of the cerebellum pushes through the foramen magnum. And as you remember, the medulla is right close by. So if you have something pushing against the medulla, that's not very good. The medulla has a number of respiratory neurons that may be affected by this. So one of the ways that this person could present is with sudden death. That doesn't really help you very much if your patient presents with sudden death. But you should be aware of the fact that when a person has a hemorrhage in the cerebellum or a stroke in the cerebellum, things could get tight within that posterior fossa, and tonsillar herniation is one of the things that you worry about. Maybe before the sudden death, you may be able to pick up subtle lower cranial nerve deficits such as dysarthria and dysphagia. External herniation is not quite as clinically important or necessarily that interesting. It is really just when the brain exits the intracranial vault due to either a trauma, a rupture of the skull, or sometimes iatrogenically. You can see here the brain is rupturing out through the intracranial vault. That concludes our section on our brain anatomy and brain vasculature.